Welcome to this expert summary of the European multiple myeloma treatment practices in 2011. We are here together in Amsterdam with a group of experts, myeloma experts, and today we will discuss problems and issues that are facing the clinician who's treating patients with multiple myeloma. My name is Pieter Zonneveld from the Netherlands here, and I will introduce the other panel members for this part of the session. So now we move to Dr. Heinz Ludwig, who will give an introduction on the treatment strategies for multiple myeloma.
I would like to welcome everybody who is listening to our program, and I'm going to give you a brief overview of the outcome of our discussion. And the discussion was based on a recent review which has been published in The Oncologist at the beginning of this year, which covered the treatment recommendations as they were provided by the end of the last year. Now we came together to update the recommendations, and we looked at the evidence which has been produced since that time. And I would like to show you the strategies we discussed. It is clear that in patients who are eligible for autologous stem cell transplantation, that basically we have two principal options. We can use a 3-drug regimen or a 2-drug regimen, and the different regimens are listed here on the figure. Those regimens which have an asterisk attached have been tested in prospective randomized trials, so we have very good evidence for those trials. And it was concluded during the intensive discussion that 3-drug regimens are now the treatments of choice because they are highly active, render extremely high response rates, which go up to 100%. So whenever possible, a 3-drug regimen should be used for induction therapy before stem cell transplantation. And there is some agreement that about 3 to 4 cycles should be administered before transplantation. After transplantation, we have two options. We have the option to use consolidation, and we have the option to use maintenance therapy. And this slide shows you the status of last year. And I'm going to show you what the discussion produced as of today. So consolidation is defined as a treatment which is active treatment for a limited period of time, with the principal aim to induce high quality responses, to increase the level of excellent responses, and hopefully to a level where minimal residual disease is no longer detectable. So what are the options? You can use a second transplant. This is the old approach, and now we have excellent data that with 3-drug regimens such as VTT, you can increase the number of patients with MRD negative disease. You can also use VRT. We have data with bortezomib consolidation therapy and also with lenalidomide consolidation therapy. And maintenance is, of course, an exciting and expanding field of clinical studies. We have significant data with thalidomide therapy after stem cell transplantation. Actually, 6 trials have been reported and 5 published, showing an improvement in PFS. And when you do a meta-analysis, you also see an improvement in overall survival with thalidomide. We have exciting new data with lenalidomide after stem cell transplantation. Both studies showed a significant increase in progression-free survival, and one indicates a survival benefit. And we have excellent data with bortezomib maintenance therapy after bortezomib-based induction therapy, showing an improvement in overall survival as well. Now, what are the options for patients who are not fit for autologous stem cell transplantation? The principal question is the patient biologically fit? And if he is fit, is there any complication which would render specific precautions regarding the selection of therapy? So if the patient has no specific complications, we have two major options, either to select an IMiD-based regimen, as listed on this slide, or a bortezomib-based regimen, and you will see that most regimens include 3 drugs, and there is also the option to use a 3-drug regimen or 4-drug regimen followed by maintenance therapy. If there are any complications, then we have to be particularly careful in selecting the appropriate drug. If there is polyneuropathy, we will probably opt for a lenalidomide-based regimen. If there is renal impairment, severe renal insufficiency, we are looking for a very active, fast-active regimen, for instance, a bortezomib-based regimen. In the elderly frail patient, it was felt that we have to define those patients more carefully and to start also including in clinical trials instruments which assess comorbidity and which also assess frailty more carefully than we did in the past. And of course, when it comes to the novel achievements, I think in Europe, bendamustine and prednisone should be mentioned because it has been approved for use in elderly patients who are not eligible for any other therapy, for instance, bortezomib-based therapy. What are the options at first relapse? And this depends again on the situation of the individual patient. If he had a treatment, induction treatment with a frontline treatment with a novel agent, then depending on the treatment-free interval, the relapse-free interval, you have the option to repeat the same regimen which you used for induction after a long treatment-free interval. And the longer the better, the higher the probability for a second excellent response. If this treatment-free interval is short, you should switch to another class of drugs, and that would be the appropriate option. And if you switch to another drug class, then your selection will depend on the type of treatment which you used for induction, of course. And if you had an IMiD-based induction therapy, you certainly will opt for a bortezomib-based treatment regimen for relapsing patients. If first-line treatment included a bortezomib-based regimen, then you most likely will opt for an IMiD-based regimen. If the patient was not treated with a novel drug at frontline, you most likely will, and that is the recommendation of the group, move forward to use a regimen which includes at least one novel agent. And here you have these 3 options: IMiD-based regimens, bortezomib-based regimens, or a combination of bortezomib plus IMiD-based regimen. So with that saying, I would like to conclude this introductory part.